So, first of all, I would like to say that I see from the questions that many ask about the slides from the keynote speakers. As soon as we have their answer on that, they may be distributed via email to all of you, but we cannot say for now. And just to remind that after the conference on Monday, you will have an email for viewing the recorded sessions for 2 weeks, for 2 weeks time. Here you will receive an email with a link that you can have access for 2 weeks to the sessions. So, Magnus, I'm very happy to be here and introduce Magnus Hald. He is a psychiatrist, and for over a decade, he's the director of the Division of Mental Health and Substance Abuse, University Hospital of North Norway. He's been long interested in the development of a network-oriented perspective on mental health, based on ideas that have come from his work with reflecting teams and reflective processes. And he's behind the Med-Free Clinic that started in January 2017 in Norway, and we are all very, very interested in hearing about this wonderful alternative to medication, to treatment without medication. Magnus, welcome. And unmute yourself.
It up.
That's great.
Okay.
Yes, we can hear.
Yeah. Thank you for inviting me, and thank you for the nice introduction. Now you can hear me also, and I hope that it's possible to see some of these slides, although we had some problems. It doesn't work in show mode, so we have to use a different mode, and I hope that's still it's possible for people to see. And I would also like to, I just must say that I find it, it's different to speak to a camera than to speak to some people where you can have eye contact. Eye contact over this medium here is just an illusion, and but I hope it will be in some way meaningful. I will talk some then about the drug-free treatment in Norway, or maybe rather the drug-free treatment in North Norway, because that's what I know the most about, and I might also say something about what's happening in the rest of the country. And I think I'm amazed that so many people use their Saturday night for this, and I hope it will seem worthwhile. Anyway, northern Norway. First, I would say that drug-free treatment in our facility is basically a possibility for persons with serious mental problems to choose treatment that does not include antipsychotics or better neuroleptics, which better describes how this group of medication works. I must also then, excuse my failing, my limited command of the English language, but you must bear over with that since you invited a Norwegian, and I will talk, I think, about this. First, a little about the context, because I think the Norwegian context is very important for what it has been possible to do here, and a little about why that context in one way produced medication-free treatment as an option, a little about the mandate that we got when we started to establish this, and how we decided to organize, and how the program has been, and a little about what we have achieved maybe. So first about the context. Northern Norway is far north. You can see the map here with the Norway, kind of the coastal line of the northern part of Europe. We border both Sweden, Finland, and Russia. And there's always been a close connection between the people in this region. Tromsø is located right there, and that's where I'm sitting now. And Well, the cooperation that we've had with the other countries, also in the field of mental health, made us re-establish a lot of the contact that we used to have with Russia from in this part of the country from around 1700 until the revolution in 1917. And there was a special strong connection between the Archangels region that you can see on the White Sea and the northern part of Norway. It was actually so close that they developed a common pidgin language where they could be able to that they were able to use for trading and for sharing things. So that was a very historically a very important connection, and it was re-established during the period of perestroika and glasnost. And so I traveled to Archangels together with Jaakko Saikula and Tom Anderson for, I think it was 3 or 4 years. We traveled a lot and had, some kind of training program going on there. And the Russians, they called what we were doing for democratic psychiatry. That was the Russian idea about network-oriented practices. And I actually, when I've been thinking about that lately, I actually think that democracy is an important part of the context for the Norwegian context. And democracy in Norway, and I think in many parts of the world these days, it's important to talk about democracy because democracy is kind of threatened in many parts of the world. And I also think that democracy in Norway has some special features. It's characterized by, the differences between people, the differences between people that are rich and the people that are poor. They're not as big as in other countries, and we have a system with to a very large degree equal opportunities for people when it comes to education, jobs, and equal access to healthcare. And in Norway, the healthcare system is basically a public system, and it's this also then goes for mental health, and it's organized in this way: primary healthcare is a local and town responsibility, and specialized healthcare is um, state responsibility, and it's organized what you might in a way on different levels. Um, yeah, so it's organized. The specialized healthcare is organized in 4 regional health trusts, and here you can see the 4 trusts. It's one in northern Norway, and 3 in the southern part of Norway, and the northern part, the Northern Norwegian Health Trust, is where we are located. And it's a very large geographical area, but it's a small part of the population. It's some 10% of the Norwegian population, and the Norwegian population altogether is a little more than 5 million. So it's, just around 500,000 people in this area. And the university hospital is a university hospital for this whole region, and has a psychiatric hospital for parts of this area and the psychiatric centers for even smaller part. There have been 2 central messages, so to speak, for the healthcare system in Norway for quite a few years. And the one idea which is very strong with the government is that we should now have the patient's healthcare system. And that means that the interest, the experienced interest of the patients and the patients' organizations should be decisive for how we organize and also in clinical work. Like the late Health Secretary Bent Høie said this in 2015. The basic question is, if the patients were given the right to decide, how would we organize and run the healthcare system? This is a radical question. The answer we get should be taken seriously, and it should be decisive for the work with the patient's healthcare system. So that's one of the bearings, so to speak, for how we organize. And the other is what's called the golden rule, which of course is the law of reciprocity. reciprocity in many religions. You should treat others as you want to be treated yourself. But in Norway, that's not what people will think about. If you ask people in healthcare what is the golden rule, they will say it's the it is that treatment programs in mental health and substance abuse shall have a higher yearly growth than programs in somatic medicine. And this goes to all these measures, numbers of employees, waiting time until consultation or treatment, number of outpatient consultation, and economic growth. So that's been a goal for almost 15 years now within healthcare in Norway. And although it's a goal, we have never really achieved it, and there are different mechanisms that's debated a lot all the time that makes it difficult to really achieve this goal. But at the same time, it has resulted, I think, in more resources to mental health care than in many other places. So why medication-free treatment? And then I must say that, the medication-free treatment is not in Norway an idea that came up within the medical or psychiatric community itself. Not at all. This is solely a user or this is organization. This is something that users and organizations have demanded for a long time. And it's been very difficult to get through with the idea of medication-free treatment. And the government for a period of time would say, well, there are so many different opinions. We really don't know who to listen to. And the professions, they don't think this is a good idea. So it took a long time. But then in 2010, different service user organizations, they united, and it was actually not possible not to listen to them anymore. So these different organizations joined. Almost all the Norwegian user organizations or advocacy groups joined, or except the ADH group, which sometimes some people say that they want more drugs and not less drugs, but the other organizations, they joined. And the health secretary had to, tackle this demand from the user organizations. And what he did was he told the regional health trusts that they should establish this in one way. And the way things is being told in Norway is this way. There's a regulatory document that is actually sent through the system from the government and all the way out to the providers. And what happened? Well, actually, this order was given from about 2010. And what happened? Actually, in 2010, nothing happened. 2011, nothing happened. 2012, nothing happened. So nothing happened. Although this is what was stated in this document almost every year, that patients in need of psychiatric help shall, within prudent frames of treatment, have the choice of different treatment options. Amongst these treatment options that do not include the use of medication. These options shall be developed in close collaboration with the user organization. So I think then the health secretary got kind of fed up. So in 2015, when nothing had happened, there was sent a special letter to all the regional health trusts. And in this letter, it said that each regional health trust shall establish alternatives to medication, including help to tapering and termination of use of medication, and help to establish other therapeutic treatment measures. And also for patients that are admitted to psychiatric treatment facilities and that are being treated with medication, there should be made plans for tapering, termination of the treatment with drugs. I mean, this goes for patients that are admitted to the whole psychiatric system in Norway, actually. And also to obtain experience with medication-free treatment of patients with serious mental problems, each regional health trust must establish at least one bed unit reserved for this purpose. So this was a kind of an order, and it was very strict, and it said you have to do this within half a year, or we'll come after you. That's basically what the government said. So it became impossible for the different health regions not to do anything about this anymore. And the health minister, he demanded that this was done in a specific way, that the different regional health trusts had a discussion with the affected user organizations, and that they had to come up with a unified proposal for how this should be done. And when they both parties signed this proposal, then they had done what they were supposed to do. So he made he said that you have to have an agreement with the user organizations. Each health trust has to make a plan with the local user organizations about how you can come about with this command that you've gotten from the government. So this is how it came, and yeah. So these were the three or the main things in this order that was given from the government. And I think there were special things with it. It's both the drug-free thing, and it's also a new thing for us in Norway, at least, that user knowledge should be included on an equal basis in the planning process. For a long time, users or people with patient experience and things like that have been included in planning processes. But this, I think, was the first time when these organizations were included on an equal level. So we should have this regional plan, and we should make a local plan. And so we kind of got at the hospital here, we got the regional protocol, and from that protocol we were supposed to make a drug-free bed unit, because the protocol said that there should be established. We should give priority to establishing 6 beds, and it should be done at University Hospital in Tromsø. The reason we got it was because no one else wanted it, and we said we wanted it. So there was not a big competition. But at the same time, it was said that the drug-free program should have a regional responsibility. So that was an important part of it, the regional responsibility. And that, of course, 6 beds and the regional responsibility was and is very challenging, which I will come back to. And it said in the protocol that the drug-free treatment should secure choice options for patients, is a part of a major effort to reduce the use of psychotropic drugs, is based on patients' choice, should focus on cooperation with local treatment programs, should include recovery perspective, should be network oriented, should they engage families of patients, focus on activity, job, school, network, help patients be independent, employ people with own experiences. Patients and employees must together develop a program that they can believe in. So we have been told that we have to believe in what we're doing, and we have to follow also national treatment guidelines. That's been challenging because the treatment guidelines are often full of drugs. The Norwegian treatment guidelines are very closely linked to the NHS guidelines in England. I think they often translate parts of it, or at least they use it as a very big inspiration for creating local guidelines. It says also that it shall be based on the main ideas from the user initiative, and that was that patients shall not be subject to coercion or pressure to use any kind of medication. And I think that's one of the reasons why the user organizations thought that we needed specific places for this, that we can't say that, this is an offer that should be given within the ordinary units that we already have, because there's so much medication there that it's very difficult, I think, to really differentiate between different patients in a way that makes patient not experience some kind of pressure to use drugs. And the most important aspect of the treatment is to provide a safe environment, a bed to sleep in, someone to talk with, and regular meals. And I think that's very good, although colleagues of mine have said, well, this cannot be specialized mental health services. I think it's a very good idea, and one should also emphasize on the development of good treatment culture for drug-free treatment that can contribute to the development of new needed knowledge. And drugs shall not be an important part of the treatment that is offered, but shall not be refused to patients that want drugs. So it's kind of open in that respect. And these were the criteria they said we had to use when admitting patients. We have no coercion, only motivated patients, priority to patients with psychosis or bipolar disorders, referrals only from specialized services, no acute admissions, no patients with major problems with substance abuse, only safe therapeutic procedures, what that might be, and tapering of psychotropic drugs prior to admission. The last point there, we had to, to really, that was not possible. From the first day, we understood that, tapering is a major challenge for people that have been using drugs, and all people with serious mental problems in Norway, at least 99%, are exposed to drugs at some time. I think it's very difficult. So, and we saw that people that have been using drugs, they need help to taper. So from the very beginning, we said, this we can't follow. We have to be able to help people taper drugs. And we have noticed that the knowledge about tapering is very limited within the medical community in Norway. And we look at it as one of our major tasks is to kind of spread the knowledge about this. Although, the development of drug-free treatment programs have really focused on this in many ways. So in Norway, the Norwegian Psychiatric Association has made their own manual for tapering antipsychotics, but it's not very good, I would say. It's based on very limited experience and little knowledge. But I think it's a good idea that they've done it. I mean, they've tried. How to organize? We tried to find out if there were any similar things anywhere else, and we find that there were no other places that we could find that where they had tried to organize this kind of programs within the public mental health system. So we of course were aware of Soteria projects, different places, and we looked into some of them, and they seem to use more drugs than I would have expected from Soteria places. But I think new places have been developed since we started this project here back in 2017. And we, from the very beginning, it was very clear to us that we have a huge area, and we need to be able to offer treatment, although I don't think treatment is a good word, but I use treatment, but probably collaboration would be a better word. So we had to, be able to collaborate with patients from this whole region, and to be able to collaborate with more than 6, it would be a very good idea to try to make the programs together with local psychiatric services. So we have, from the very start, been very occupied with establishing what you might call the network-oriented program. And I think the network and web perspective and the recovery perspective is very central for the program. And generally, you're confronted with a treatment chain when you try to plan psychiatric services. At least in Norway, we try to use treatment web as an alternative to this. And we think that the web perspective makes these features more in the foreground, so to speak, while a kind of at least in Norway, I think when you treat people in a kind of a chain understanding, you will basically communicate with people in other parts of the system with written material. We try to always work in a very concrete network perspective. So we would say that the drug-free treatment unit should be a new possibility in the treatment mental health treatment web, so to speak. And then also recovery, and these recovery can be talked about in very many different ways. I won't talk very much about it now, but it's it's a well-developed way of thinking about mental health problems, and these are some of the headlines that I find meaningful. I think this goes actually back to the civil rights movement in the United States in the 60s and 70s. That's when today's recovery ideas started to be developed, but I don't have time to say more about that now. I'll say a little about the program, the concrete program, and we will then get written referrals from service system and the patient, she or himself, and we will then generally meet with everyone involved on live or Skype, and that will be, the patient, the private network, the professional network. So we'll generally start the treatment or the contact with us with such a meeting, and we will have meetings like this throughout the process. And patients will very often, after a meeting like this, come to the ward and stay there for maybe 1 to 3 weeks, and then stay at home for maybe 1 to 3 months, and then come back. That's a typical way of meeting with us, and where we are involved in the program all the time, and we will have network meetings, intermediate network meetings, either when the patient is in the ward or when the patient is at home. So we will say that our treatment or collaboration is both through these network meetings and through the development of the treatment network, and through what's happening when the patient is in the ward. So there's, in one way, two parts of this treatment program, so to speak. Yeah. So the unit placed in the treatment bed is the one part, and the daily program in the unit is in one respect another part, where we have these different things that I can say. We have recovery workshops 4 times a week, where we have discussions amongst the patients that are in the ward and some of the personnel in the ward, where they share different experiences around different themes. We generally have one theme a week, and some of the themes are generally being repeated maybe once every half year, or sometimes even more. And then we have physical exercise, a program with physical exercise, which is something that's for everyone 3 times a week, and then there are individual training programs, and we've had a lot of emphasis on physical exercise and training. There's art therapy, and now also some music therapy, both in group and individual. And then I see the time is running fast, so I'm going a little fast now, but
Don't worry.
we have had some experiences. I talked earlier about the rules for admitting patients, or the guidelines for admitting patients. We should have no coercion, and that in Norway you have to have no coercion. You have the capacity to give an informed consent, and the capacity to consent is sometimes difficult to evaluate. And what if the capacity to consent changes during stay in the ward, for instance, or during the program? How should that be? How should we look at that, and what can we do in such a situation? That's an ongoing debate. We should give priority to patients with psychosis or bipolar disorders. We have had quite a few patients that really don't identify with diagnosis that they've been offered by the mental health service system, and they prefer not to have diagnosis. And we don't pay too much attention to diagnosis, but generally will be engaged in the treatment programs for patients that have been exposed to neuroleptics, or that are in a situation where where the system thinks that they should be exposed to neuroleptics. So we won't stick to diagnosis when it comes to who we offer in this program. And then referral only from specialized services. I think we're backing down a little on that, and thinking more about, we need someone to cooperate with generally, but the network is not just specialized services. The patient's network consists of very, very many different agencies and persons and families and things, and I think we don't stick too closely to that anymore. I don't think. No acute admissions. Some say that that's when it's most needed, and the patients that are in our program, some of them also come acute. So we say that, well, if you're so to speak, enrolled in our program, then you might also come when you're in a more acute situation. Only safe therapeutic procedures, well, that's also a question what that is, and we are not supposed to be an alternative, like alternative medicine thing, and we have to, in my experience, it's important for us to remain a part of the system, to be influential in the system. if we become too different from the rest of the system in this hospital, no one would listen to us at all. But as long as we are just appropriately different, we will be listened to. And so I think that's important for me to stay appropriately different. And as I said, tapering of psychotropic drugs prior to admission, that's not been possible at all. And we have used, at least especially in the beginning, we used a lot this harm reduction guide to coming off psychiatric drugs, which most of you will know, and also this guide from Volkmar Aderholt and Peter Stensley, when a guide to minimize minimal use of neuroleptics. So we have had good use of that, but we of course rely very heavily on the different people's own experiences, because most patients that we meet have experiences, of how they've tried to taper drugs, and many have bad experiences, and we try to discuss, how can we make it a better experience. So it seems to us that the patients on a very general level report two parallel processes. First, the gradual reduction of drugs, which is a challenge because we don't have the formulation of drugs often that is small enough for the last part of the tapering. We, for a period of time, used tapering strips that we imported from the Netherlands, but then the Norwegian Drug Administration said that they're not produced according to European rules, so you're not allowed to import them anymore. So we won't get them reimbursed, so we can't use those tapering strips anymore, which is very bad, I think, because we had very good experiences with using tapering strips, because that made tapering so much easier. It's more difficult for many patients to use a knife or to sit there and try to deal with the drugs, especially when you're supposed to have small doses. And also then the gradual increased access to feelings and thoughts, that's been to a much larger degree than I thought in the beginning. And positive experiences seem so far to outweigh negative experiences. And then what have we achieved? I think to put this on the agenda, and since we're a part of the system, I think we're in some ways more threatening to some people that are very medically oriented than we would have been if we had been outside of the system. So there's been a debate, for instance, already in 2017, there was in the Norwegian Journal of the Norwegian Medical Association, where central Norwegian psychiatrists went against us. And also, some of you have seen this article in the Journal of Psychopharmacology that some colleagues in a hospital in the southwestern part of Norway, they interviewed one another. They called it a qualitative research project, and they said that we're all against this because we're all responsible and we're all work evidence-based. So we have had this, and this is, for instance, this is the leader of the Norwegian Psychiatric Association. That would be like the president of the Royal College in Britain, I think. Redistribution of resources to medical free treatment offers that do not have a documented effect on those with psychosis, makes the situation, that's the economic situation for mental health, even worse. Several places, important psychosocial treatment offers for those that need them the most are closed down to finance medication-free treatment offers to others. This, I think, is bullshit, and I have told him so. And then to finish up here, I think also these things is important, and we also have some patients, and actually we have some very strong advocates that have been taking part in our program, and that most of them have, and many that have been, in the newspapers, on television. And we have one that those that are interested can find in on the BBC BBC page. Yeah, I will drop this, and I will then say that we hope to be able to present more solid data, so to speak, to to present more. And we were late to establish this research project, but it's going on from this spring, and we are also including some patients that have been with us from early on, from when we started. Yeah, I think I will not say any more because I'm over time now.
We cannot do everything at once. So
Yeah.
first you had to set up the training.
Thank you.
I think, thank you, Magnus. Can you please stop the share screen mode so that I can see you? Because I think that you're frozen. So your camera may be frozen. I don't know. I don't have any feedback from the others, but I think that it is frozen. So now you can hear me?
I can hear you. Can you hear me?
Good. I can hear you, right? But I cannot see you.
You cannot see me?
No, I can. Okay. Maybe this would work. Thank you. Because we have a lot of questions. What's your experience in Norway? Has a lot to offer to all of us, I think. And are you okay with me asking you questions now?
Absolutely.
Okay. So I have a comment about that still psychiatrists can also medicate you, even if you go, if you have people in the clinic and then those people come out and they may be facing an acute phase or something, or a personal crisis. And then since you do not accept acute, you're not allowed to have acute patients, let's say, and then the system can always put those people back in medication. Is that true? So it is only in your clinic that this med-free treatment exists.
Yes, it's only in our clinic or our, the drug-free treatment unit where the goal is to try to give people treatment that do not use psychotropic drugs. So that's something that's only, is the only purpose that we have. But if you go to an ordinary acute ward in the hospital, we have 3 acute wards here, then you will generally be offered psychotropic drugs. But since we are part of the hospital, if there are patients that have a lot that are in our program, first of all, we will often, even if they have an acute episode when they're a part of the program, we will generally take them in, even though we're not supposed to do so. And also, if patients are being admitted to a different ward, they will generally ask us, "What shall we do here?" if they're a part of our program, and then and so they will generally be less likely to medicate the patients that are in our program if they're also admitted to other wards.
Okay, thank you. And what is your, I have this wonderful question. What is the most important experience for you being part of this unit so far?
I think what's made the greatest impression on me is that we have had some patients with very difficult stories, for very long stories that have, really changed their life during the time that we were in contact with them. And that's made a very great impression just to see these. There are not very many that have this, very big, where it seems to have this very big change, but you have seen some of them. I've seen some of them, and that makes a very great impression. So I think that's important, and that's I think what's made really impressed me the most. But then at the same time, I also think it's like I said in some of the last slides. I think it's important that we are that we get the debate more up, and that it's possible to have some kind of a discussion in the field, because I think often there are when it comes to psychiatry and also to other parts of medicine, I think it's a very in many respects they have traits that are very close to oppression, or systems of oppression. You know, they're characterized by the tendency to medicate, the tendency to not be able to disagree and not have discussions. So there are very many different traits that are, you know, that you can identify with systems of oppressions that also comes into mental health and medicine as a whole. And one often, you know, say that's because we have this knowledge that we are allowed to. But that's that we can say, you know, what people should do. But that's actually a very authoritarian position to have.
But it is a very common one, and I think that you partly answer another question. Was why are psychiatrists so defensive when people speak about drug-free treatment, and why is this the case? Is this authoritarian?
Yeah, I think often psychiatrists they have an experience that drugs are useful. I think that, and I think that, and, so I think generally, I think that they do a good, that they do the right thing. And you know, you don't, the way you see things, it's very often seems to be the right thing to do. For instance, we will often, or at times, I worked a lot in acute psychiatry. Our patients will be admitted to the hospital because they have deteriorated or have big problems, and very often that will be connected with the stopping of using drugs. And so the general idea then will be, well, this person stopped using the drugs, that's why she got the problems back again. But when you examine this, which you know, often you will see that the patient got in big problems, and after getting big problems, stopped using the drugs. So the patient so there may be many different explanations to this, but it seems to be a general idea, and it seems to be a you know, this kind of reproduction of, you know, the ideas of this is useful in a way seems to be, I think, central.
That's true. People ask, is your facility open to visits? If it is, I would like to come, please.
It is open.
Or could you maybe support other organizations, maybe through training or something like that?
We are very open to visits. So that's because we think it's a part of our job is not only to try to give an offer to concrete patients, but a part of our job is also to try to spread the ideas. So that's an important part of the job. So therefore, we think visits is very good. It's difficult for us to take. We have had some people that ask if they can be patients with us from other countries, and that's not possible. It's only possible for people that live in Norway. And most of the patients that we have is, of course, from the northern region, but we have also had some patients from other parts of Norway, because within the public system in Norway, you are supposed to be able to choose to be treated wherever you want to be treated.
So we cannot be a patient in your clinic if we don't live in Norway, but
when you live and work
online?
in Norway, then you can.
Okay,
it's just
then
to live and work in Norway then.
And then how about online treatment? Do you offer
we
online treatment?
We have not had any of that, no. No, and I think what I would like us to develop more is you know, maybe an outpatient part that works with tapering, because we don't have any place like that, and the knowledge about tapering is not good enough amongst colleagues, I think. So it would be good to have a place that kind of gain experience on helping people to taper medication, also other psychotropic medications than neuroleptics, which is what we generally work with, although there are also other drugs that people use and that we help them taper when they're with us.
So people come and stay for how long on average, and then come off completely?
Very often. That's very individual. We have some patients that have stopped taking drugs when they come to us. We have some patients that decide that, well, we want to stop using the drugs very abruptly now. And we have some patients that want to try to follow a more guided slow phase tapering. And when they do that, it will often be tapering that takes somewhere between half a year and 2.5 years. So that's our experience. So we use long time with some patients.
Okay. So thank you very much. I'm really sorry that I cannot see you again, but what you said was very, very interesting and very, very hopeful. And hopefully we can exchange information and knowledge, and there will be some networking through this conference, or from this day on at least.
Very good.
Thank you very much, Magnus, for being here, and it was an honor. And now we're going to have again a break for half an hour before this discussion that we're going to have afterwards, that is focused on what can we do from now on to support withdrawal. Thank you.
Thank you.
Bye. Bye, Magnus.
Bye. Bye.